time zone. I'm Scott Malaney, CEO of Blanchard Valley Health System, and once again, my partner in crime to my left, Dr. Bill Kose. Pardon me. We're back again, ostensibly to talk about COVID. There have been a number of questions posed to us. Before we get into the meat of the discussion today, as always, we really would appreciate you giving us feedback. If these are helpful, we will continue to do them. If there's a better way, if there's a different subject, please let us know. So with that, Bill, welcome.
Thank you. Thank you.
We have a number of questions, and feel free as we're going along to type in your questions. We'll be glad to try and pick up on those as we go also. First question is from Melinda from Findlay, Ohio, and says, we'll let Dr. Kose handle this. It's a pretty broad question. What have we learned about the virus, excuse me, since the last live stream?
Well, if we look back on it, let's just say the first of the year when this started in China and when it came over, I think things that are different than what we maybe expected was that the mortality may not be as much as what we thought. This certainly is a contagious virus. I think we've been able to demonstrate and to be able to see that. It is a coronavirus, so it acts like a virus from a standpoint of the transmission of it. We've pretty well been able to say it's going to be either aerosolized coming in the air, or it's primarily being spread by droplet contamination from sputum, from sneezing, from coughing, from things like that. So we've learned a little bit more about it that way. The other thing that I'd say, we do know a lot more about it genetically. There's been some mutation, but as far as what the scientists are saying, it doesn't appear that the mutations have changed that much that it's causing different kinds of infectivity. Since we don't have any real treatment, like antibiotics and things like that, it's hard to tell if there's a resistance. But overall, I think what we've seen is it's very contagious, especially in certain groups, as we've talked about, but not that much new.
And thank you for that question. Kathy from Van Buren, Ohio, is asking us, since many are wearing masks because of COVID, do you foresee a lighter flu season this year? That's an interesting question.
Yeah, it's really a good question. And Kathy may have seen somewhere where there have been studies done in South America. There was something that I saw over the weekend that took most of the South American countries and looked about the number of flu cases or influenza cases that usually occur. Now, they're on a different cycle than what we are.
It's winter and
summer,
yeah,
right.
Yeah.
But with everyone wearing masks in almost all of those countries, they did not see any, almost no flu. Now, people got flu shots down there, et cetera. But as compared to 2018, 2017, there was a remarkable reduction. And that just makes sense because the influenza, it's a different kind of virus, but it spreads the same way. It's a respiratory borne. So again, with sputum, with droplets. And if you use a mask and you use the protective kinds of things that we've talked about, social distancing, washing your hands, respiratory etiquette, that you would expect to reduce all kinds of viruses that would occur. And that's what was shown. So we've got some real data to say the epidemiology of this statistically and scientifically that it should make a difference. And I think there may be some questions that'll be asked or we can talk about later is what's going to be really difficult is telling the difference between influenza and coronavirus from a standpoint of COVID, of what we'll be seeing in the offices and the emergency room.
Well, that's an interesting one. So that'll be one we'll all be keeping an eye on in the northern hemisphere.
Yeah, there really aren't too many differences in the symptoms, and that's been one of the things that the people have talked about is for influenza, most of us have some immunity. We've either been exposed, the herd immunity that's talked about, and you've been able to keep your cells in your body that will respond to infection. In addition to having influenza, a vaccine, the flu shot that people get. And then we do have some kinds of treatment, but the symptoms that people are going to have are going to be about the same.
Thanks, Bill. And And thanks for that question. Lori from Ottawa, Ohio asks, will the flu shot give me any protections against COVID? That's one, as you know, I asked you the other day. I went and got my flu shot. I got my Daffy Duck Band-Aid on my shoulder, and I was feeling pretty good about that. And I was thinking, I wonder if this is going to help me at all with COVID.
So what did I tell you?
No.
That's true.
I guess that's
So
a short
yeah, that's the short answer. It may be a little bit.
A little disappointed in the answer, by the way.
Because part of one of the things that we are learning more about, it's not just with COVID, is how sophisticated our immune system is. And by what that I mean is that we develop antibodies when we have an infection, if it gets in. Those antibodies are not that specific to each virus. So there is some cross reactivity. It's not very much, and these are COVID virus is different than influenza virus, but it does appear that there may be a little bit of help that you've had this. There was an article that came out the last couple of days that individuals that have had the common cold recently may have a little bit of antibody that's going to work against COVID. So to say categorically it isn't going to help, but one of the problems that, as we talk about vaccines, what happens is society thinks, well, I've had the flu shot or I've had the vaccine, so I don't need to do anything else, and that I'm going to be protected. And the flu shot's not going to do anything like that.
I will say your answer now is much more hopeful than what you told me the other day.
Yeah, well, I was in a hurry when I was talking to you the other day. I
Fair
got
enough.
more time. I'm sitting around here.
All right. We'll move on from that one. Kylie from Arcadia asks, and this is an interesting question too, is testing going to change now that it's flu season?
Well, I don't think from a standpoint as a practicing physician it's going to be any different. We may start testing also for influenza. Part of the problem is we don't have an awful lot of tests for either one of those. They're just not that readily available. The symptoms are fairly similar, as I've already said, and in deference to what's going on in schools and what's going on in businesses and here at the hospital about quarantining people, we are, I think, pretty obviously as a society and as institutions a lot stricter in we are going to quarantine somebody with COVID versus somebody that has influenza. But I think as far as are we going to test more often, are we going to do anything any different, we will say if you've got those symptoms, COVID testing is appropriate. We may add influenza, but I think that depends on whether we start to see influenza cases. If we don't see a lot of it, I don't think we'll do a lot of influenza testing. At least I wouldn't be ordering it.
Yeah, that makes sense. Yeah. Corey from Finley asks, is convalescent plasma being used as a treatment locally? And by the way, Bill, when you answer this, I appreciate maybe if you could define what convalescent plasma is for people. And where can I donate if I have the antibodies?
Okay, so here, as we're talking about treatments for COVID, reiterating some of the things we've talked about before, we don't have a treatment for the virus like an antibiotic that's used for bacteria. What your body does is it produces from the antigen, which is the virus. When the antigen is in your body, your body makes immunologically, or your immune system makes antibodies to fight the antigen. And there's different kinds of antibodies. Without getting, again, I talked about how it's just amazing how sophisticated our body is of the things that we can do. We have B cells and we have T cells and we have different things. Those different antibodies rise at a certain a time period, and some of them very quick, some of them it may be a couple of weeks, and then some of them remain around. And so when you get this antibody, or when you get the antigen exposure later, it will prevent you from getting the infection. So what was thought from that, I mean, just looking at it logically, let's say I had COVID 3 weeks ago. If you draw a test to see if I had it, that's one of the tests that we do. The test is positive, so I have antibodies. Well, if those antibodies could be given to Scott, who now has COVID, it would make sense that that would help him fight the infection. It's going to help me fight my own infection again. It's going to help you. So this was one of the things that President Trump was given, was one of the research that's being done using this, in that case, a synthetic antibody that looks like the same thing that we would manufacture. So to answer the question, yeah, it can be effective from a standpoint, we think. The trials have shown, yeah, it looks like it's probably helpful. We're not sure when's the best time to give it, early, late, after someone's having lots of problems. But with that being said, it does look like it's effective. What we are doing here is someone has had COVID, antibody positive, would be to check with the American Red Cross in Toledo, who are, you can donate your plasma, the blood to the unit, and then they're making it available. We have been working with Mayo Clinic on their original research. I think now FDA has approved it. It's not seen as a research, but it is something that, and we would encourage people to do that because we are using it.
So we would, if we felt we were an appropriate donor, we would contact the Red Cross.
Yes, right.
Can we help them do that?
Yes, if someone called in here about donating blood, Bev works with that. We would get people to the right place.
I would say if you're inclined to do that, 423-4500 is our main number, and ask for administration. We'll definitely help you figure out how to get connected, because I think that'd be a noble thing to do.
Yeah, and one of the other things just about blood, because we still need blood for a lot of other things. That's one of the whole problems of medicine is we're still taking care of people with strokes and with all kinds of things. We need blood for people that have bled, that there is not a chance, I'm not going to say no chance, but the feeling is with testing that blood is very safe to be given. And so you can still give blood and not worry that you're going to get COVID from it, or mosquitoes, either one. Mosquitoes aren't supposed to carry COVID. Somebody asked me that the other day.
Is that right?
Yeah, COVID, you don't have to worry about it.
Oh, good.
Now, malaria, that's a little different.
For those of you that wouldn't know this, Bill, one day I walked into work and he said, "Did you know that half the people in the world that have died in the history of the world died of mosquitoes?" I thought, well, gee, that's good morning. How you doing?
Yeah, this is a trivia question you can ask your kids at home tonight. That there's a pretty good theory that dinosaurs might have died with malaria. That there's this little parasite's been around. I hate mosquitoes, so that's partly why I told Scott. But dengue fever, and there's all kinds of things. So,
Jennifer from Finley asks, "Are the experimental treatments used for President Trump being used locally?"
That's a really good
That's
question.
sort of a yes and no question. Right?
It is. The one experimental drug he got was the cocktail that you've heard probably of antibodies, these synthetic antibodies. Regeneron, I think, was the company. I originally had thought maybe they broke the code to do it. I think they were far enough along in their tests to say that there was really good reason to be able to use this, to be able to give it. And I read somewhere yesterday that I think there's 10 people that have received this. It's not gone through full FDA approval, but that would be one that we would not have the availability. I talked to Dr. Ratnasamy today, and he confirmed that's not something we'd have. The other 7 drugs that he received would really not be experimental. Now, hydrochloroquine was not used. The antibiotics were not used. Some of the things that were originally talked about, zinc, vitamin C, vitamin D, have theoretical reasons why they might be of use. Probably not going to hurt anything. He was placed on an aspirin. That would be to protect from blood clots, which the inflammatory response of what occurs with COVID is one of the long-term problems that people can have. So again, that would have made sense. And then he was on remdesivir, which is what we're using. The one that it's not so much controversial. It's not that big a dose as using steroids. And dexamethasone was being used. We use dexamethasone here. It's really the theory of why it's being used is it's your body reacting to all of these chemicals that are being released by your body itself. You're attacking yourself. And it's usually used a little bit later, but talking to Nate today, a lot of physicians are using it a little bit earlier on, but I wouldn't say any of those except for the first one were experimental.
Okay, thank you. Marissa from Finley is asking, what are the current visitor guidelines? I'm assuming they mean at Blanchard Valley Hospitals. The quick answer is you can have one visitor a day plus clergy. So we've maintained that for some time now, and seems to have worked pretty well. So same guidelines as we've had for how long?
Since once we started to have visitors, originally we didn't have anyone. We weren't sure how contagious this was. The community has been really good about this. As a physician, I'm still concerned about people being able to bring things in. They may not even know that they have it. Probably the place where we've had and we were talking about this at noon, is the end of life of, just trying to balance both sides to that. But again, the community has been really good, and the visitor policy, we're, I think, conforming with what most institutions are doing.
Barry from Finley is asking that some local school systems are having students return to school 5 days a week. That's true. Is this concerning to us as a health system, especially given that the numbers are higher than they've ever been?
You have any
No,
comments on that? Okay,
I really don't.
So it's as much of a social answer to this as it would be from a medical standpoint. So I can take the position as a physician that if none of us ever got in contact with anyone, then we probably wouldn't have a virus being spread. It's got to go. But that's not really realistic. Now, I will say, and it probably will come up about masks, that the head of the CDC said last week, if everybody in America wore a mask and did what you're supposed to, this epidemic would be over in 12 weeks. He's a doctor, knows more than I do. He's an infectious disease kind of person. But we know that's not going to happen for whatever reasons. Now, with that being said, at the schools, there was an article in the Courier today that talked about this. It sounds like the school sat back down with public health, talked about what's best policy, what do we need to do to try to minimize this. We're not a red county. We don't have that many cases. I think what I've learned from this, just talking to school teachers, is we're all worried about, well, first graders, they'll never leave a mask on. They're not the problem. The problem are the junior high students. I'm stereotyping, I don't know whether that's fair or not, but the fourth grade and under seem to get this, seem to wash their hands, etc. And I think it's really important, especially for that group. The American Academy of Pediatrics would say this. It's really important. They've got to socially develop. We just can't have them at home by themselves forever. So I think everybody tried to balance this, and they've made a decision that they think we've been in school now for a while. They've been going back. They're going to extend it, see how that goes. So I would be supportive as long as social distance, which the schools say they're going to do, going to make sure hand hygiene, washing your hands, everybody is going to wear a mask. That it makes pretty good sense. I think one of the things we have learned with this is that if you do those things, it does make a difference. And then if you can find the person that's the contact and get them quarantined, things don't go as bad as what we might have thought in March.
Thanks, Bill. That's a good explanation. Joe from Fostoria sent in a question and says, do we have enough PPE? Quick answer is yes. PPE for us comes in a variety of different fashions, but we've been able to get shipments. We've been able to stockpile a little bit. So I think we're in good shape in that regard. So thanks for that question. Dana from Finley asks, what is the current turnaround time for test results?
So we have different kinds of tests. I'm using the technical term, antigen test and antibody test. So the antigen test, that if someone comes in and we're worried, do you have the infection now, or we're trying to make a decision, we have the availability to do about 60 a week here. That's the supply that we have. So if you do the math, that's maybe 9 or 10 a day. If you're in the emergency room and you've got a temperature, or you're in the hospital and you spike a temperature and we need to look at that, our turnaround time is really in minutes. We can get that done within an hour. So again, if you're in the emergency room, we can tell you that and decide whether you have COVID and decide what to do. for screening for elective surgeries, or if your doctor feels, well, I need to check you, but we don't need to know that quickly, and get sent over, we're doing the testing and we send those out. And we're getting most of those back within 48 hours, but we will say it's usually about 72 hours. Now that's, again, to see if you have the active infection. If you're doing an antibody test to see if you had it before, what we talked about, that's really a simpler serum test that we can turn that around in a day or so.
To illuminate on a point that Bill made a minute ago, we can perform about 60 tests a week, he said. One of the big frustrations for healthcare providers has been getting the reagents or the cartridges. They look like this, or a plastic cartridge about that big, so that we could do the test. We have equipment that could do many, many, many more tests a week. We don't have the cartridges. And so, and that's been a problem across the entire country. So, but for the most part, we've managed to get turnaround times, as Bill said, and I think we're in pretty good shape all in all. Danny from Finley asks, what's the average hospital stay for a COVID patient?
Well, the average is going to be somewhere around 7 to 10 days, maybe a little bit shorter, as we've figured out a little bit better idea of how to safely be able to send people home and what they need to do. But there's a big range about that. There's not too many people that come in that we've decided that have they have the diagnosis in the emergency room, let's say, of COVID, and get admitted that stay less than a couple of days. But what we're looking at to be able to send you home is, what's your oxygen level? Is it staying normal with or without oxygen? Do you need support for either breathing treatments? Are you able to drink and to be able to do things? And so when you look at the average, the patients that are really sick may be here for well beyond 10 days. And especially if you're on a ventilator, which we haven't had too many on, but those people, we've had individuals that may be here for 3 weeks or so. So it's like anything, that there's going to be some variation. This one's pretty broad, and a lot of it has to do with the underlying patient. So if they have comorbidities, and the elderly, if they've had chronic lung disease, let's say, they're going to probably be here longer.
Yep, makes good sense. Ladies, let me check with you. We getting any questions or comments?
We had one question in regards to if COVID can be spread by droplets in the air, why is it necessary to stick a cotton swab halfway to your brain instead of a saliva test?
I would assume that if everybody heard that test, whoever wrote in was not too impressed with sticking that tube.
Sounds like
down.
it was done correctly, at least.
Yes. Well, okay. So that's a fair question. The part of the test, and in general, is how much virus is there. So if you do the viral, let's just say, just think again. I'm going to try to explain this logically. I get the virus, and say there's 1 million particles that came in. One virus is probably not going to make me sick. Well, let's say I got exposed to that. Well, that number is going to multiply over a period of time. So it may be 1 billion 2 days later. So if you think about a test that's trying to figure out, is it sensitive? Is it going to pick it up? It's going to be a lot easier to pick it up if you have 1 billion particles than if you do 1 million, if you're doing some kind of whatever kind of test it would be. So initially, I think we've learned a little bit about maybe the testing in general would be, if it's early on, the farther that you get back into the area of where it's really growing, which is the back part of the nasal pharynx, or if you're concerned that it's down in the lung, that somebody has an infection, sounds like they've got a lung, let's say bronchitis, or a chest x-ray shows something, the farther that you can get closer, the farther down you go, the closer you get to where it appears the virus is more. So that would be the reason. We have found out, though, that we can do for screening for elective procedures, we can just do it in the back of the throat. One of the interesting things that's now being talked about is just doing a saliva test, which is maybe part of what the question is, because that's been out. It's not as sensitive, so it may not be picking up as many cases, at least early on. Partly it may be for what I said. It's just not at the right place. The viral load's not that big, but it seems to be pretty good about saying you don't have it. And so there are more and more saliva tests that are now being performed, but I will say they are not as accurate, maybe accurate enough. It depends on how you want to argue the situation as the testing we're doing. But that, again, long answer, that's basically the reason. But the point, the other point, I just read something that somebody had put one of these down and they got cerebral spinal fluid out. So, I mean, it is a test that can be dangerous. And if you think about it, you're pretty close to the brainstem when you go in, and with a wire, you need to know what you're doing. And plus, it's not comfortable. Not trying to make anybody nervous.
Jeez, that sounds great.
Yeah.
Well, thanks for that one, Bill.
Yeah.
Others?
Not yet.
Okay. Greta from Finley asked, this is one I'm going to take a shot at, but I'm going to also give you a shot, because I think it's a great question. It was so public. What measures do you think could have prevented a large number of cases coming out of the White House? You know, I probably shouldn't even say this. My first thought is a different president, but I didn't really say that. So I do think some of the obvious things Dr. Kose has already talked about would have been very helpful. First of all, they were indoors. I am no scientist, but I have read enough and I've experienced enough to have a pretty strong sense that the ability to pass a virus on indoors is immeasurably different than outdoors. When you're outdoors, you are automatically in negative air pressure. There's some breeze, some air moving. Whatever comes out of your aerosolized mouth gets moved on. Indoors, it's much more difficult. But wearing masks, staying 6 feet apart, making sure that you're sanitizing your hands is the big three. And it appeared, at least, that none of those three were particularly high priority. So I'm guessing that probably behind the scenes that's true also. And the results seem to be fairly predictable. The other thing I'd ask you to comment on, Dr. Kose, he was explaining this to me recently, that it appears that there are certain people that are kind of super shedders, that for whatever sets of reasons, as they trace you back to where did you get the COVID from, there is some people that it's a whole bunch of people got infected from this one spot. And I think it's possible, at least, that there might have been a super shedder somewhere in the process too.
Yeah, I think I would completely agree with everything that Scott said. That just talking about this, when the original first question was, what have we learned about the virus? I don't know if this is about the virus. What we've learned about us is that there are some people that, when I use this million or a billion or whatever, is that there are some people that really are super spreaders, that they put out a much bigger viral load than what others do. And we've been doing a lot of, not here, but the scientists or the science of this have been looking at the genetics of the people that are doing that, and they don't seem to have the same immune response. And you can't identify that unless you do genetic testing. So that's one thing.
So their body doesn't produce as much immune response, and therefore more of the virus is spreading out.
Exactly. Okay. That they, and then there seems to be some people also that I was it in Idaho or Montana, that at a choir rehearsal, there was one person that had, and it really could, not just a viral number, but it seemed to be able to spread faster. It aerosolized more rather than just being in sputum. It was also in the air, different than what someone else was. So I think one of the things, we'll use the White House, that was the question, but in any group, if you went back then after that to try to find out who was the person that had this, and had there been, and anywhere, someone had really taken a history when you came in, have you had a fever? The things, everybody have their temperature checked? But are you aware of individuals you've been around that have been infected to try to get a little better history? That's really hard. I mean, and I understand that. But the other things that we have learned about the disease is if you're in confined quarters, you're more likely to get it, as Scott talked about. And that seems to be the reason for the winter. And you make sure of the people that are there. But other than that, if all of those things have been done, if everyone had worn a mask, everybody is socially distanced as much as you can at a reception, and washed their hands when they came in, sanitized frequently while they were there. I mean, I'm sure you've got friends that pass around. Make sure your hands are clean. You're going to be touching things. That would have been the best evidence that we have scientifically to say this is the best way to remain safe. Now, would have all these people gotten sick? I don't know, but I think one of the big things I try to tell people, there's no magic bullet that's going to take care of all this. It's a combination of all those things. Even when we get a vaccine, that's not going to take care of everybody, but it's going to be better than not having anything. Wearing a mask, I just had somebody today tell me, well, it's not going to be 100%, but if it's 70%, that's better than 0%. Not for my editorial.
Well, for sure. And I would just reiterate, and again, I'm no expert, but I have tried to read a fair amount about this. Being outside is an incredible plus if you're worried about this disease. There isn't much evidence other than things like wedding receptions where people are under a tent and there's a bar and they're dancing and all that. But they've definitely had some examples around the country of the disease spreading that way. But there's very, very little evidence of people in small groups talking to each other, whether it's playing tennis, playing golf, outdoor activities. Very, very few examples of passing the disease along. So I do think as long as the weather's good, being outside is a great place. If you feel like you really need to socialize, do it, and do it outside.
And it may be good for your immune system, just getting the exercise.
I
don't know exactly. Sunshine. I mean, vitamin D was one of the things the president got. How do we get most of our vitamin D if you don't take a pill? It's from the sun. And so that just makes good sense.
All right. So we beat that one to death, I think.
Yeah, I think so.
Elizabeth from Finley asks, I've heard many different things. This is a good one because I get asked this too, regarding quarantining after a positive COVID result. Is it 10, 12, or 14 days after onset of symptoms?
Well, what the recommendation is if you have a positive test is 10 days. And then if you've been exposed, it's 14. Now because to me, that sounds backwards. If you were sick, why wouldn't it be longer? But I think here's the theory behind it. If I tested positive right now and I'm sick, I'm already starting to get better. I mean, I don't have that prodrome or the 2 or 3 days of where I'm just carrying the virus. And so we don't think in general that once you've started to get symptoms, you're going to be contagious any more than about 5 to 7 days at a maximum of 9 to 10. So if you wait 10 days, you are not going to give it to somebody else. Now, if you're still sick, that's different. Quarantining is to keep you from giving it to somebody else. So that's the 10 days. But so let's say I'm positive, I am sick, and Scott sees me, okay, and he knows that I have that. He's quarantined for 14 days. He's got to have that 3 or 4 days extra to get sick, and then another 10 days of what's going on. So I think the CDC, at least I checked this morning, talked to our director of quality. We want to make sure that we were going to be given good information. That is what they're recommending. And I think that's pretty much what the rationale would be.
I think the thing to add on the back end of that's being conservative too, on purpose.
Right.
Because the whole point, as Bill said, is to not be able to pass it on to someone else. Nancy from Bluffton, Ohio asks us, how can I get a COVID test if I feel I'm showing symptoms?
Well, and some of this is insurance driven, this is recommendations and a lot. we require that your physician order a test for you. Now, if you're in the emergency room, there's going to be a physician, a provider there that can order the test. But if your physician feels that you need to have a COVID test, sending us an order, we will do the test. In general, it's going to be 48 to 72 hours before you would get that back. And so we would assume, let's say I would assume that if you feel and your physician feels you need to have it done, you're going to quarantine yourself until you find that out. But that's about how long it takes.
Thanks. Diane from Bluffton asks, how is BVHS doing financially right now? Are you still feeling the effects of the shutdown? Well, yes, we are. How are we doing? Much better. Once the state, the governor, allowed us to begin taking care of elective cases again, that helped a lot. Just real quickly, what does that mean? We were able to start doing elective non-emergent surgeries. We were able to start doing our pain management procedures again. We were able to start doing interventional radiology and cardiology procedures that were elective also. And when all that starts, that also means our laboratory and our radiology business will be busier. And those are kind of the big five in terms of revenue generators for us. In terms of COVID patients, I get asked this a lot. I'd say we've averaged somewhere between 6 or 7 and 13 or 14 patients pretty steadily over the last couple, 3 months. So while we definitely have COVID patients, it hasn't overrun the hospital. It hasn't been anything we couldn't handle. Pardon me. I've been just incredibly pleased with how our caregivers have dealt with all this. I probably said this before on one of these. I can't tell you the number of times staff have said to me, this is what we went to school for. We're here to take care of sick people. Don't worry, we got this. We'll be safe. We can do this. As a non-clinical person, that's pretty cool, simply put. So we are doing better. In addition, the government has provided some help, a substantial amount of help. I think our big challenge is planning for next year. Are we going to continue to see COVID as it is now? Are we going to see more? Are we going to figure out how to stop this disease and we can, quote unquote, go back to normal? I don't know that any of us know the answer to that, but our organization is prepared to deal with whatever comes our way, and I think we're doing a decent job at doing that. Bill, I don't know if you have anything to add.
No, I would say, I think that summarizes pretty well from a financial standpoint. Maybe a secondary part of the financial where I would say concern from a quality standpoint, 2 points, and Scott already made one of them. I'm really not sure this is one of the safest places you can be if you don't want to get COVID because of, we've tried to make this is normal. This is how we take care of you. And I think our caregivers now, if you have COVID or if you have another pneumonia or whatever you have, we can take care of you. You're more likely to get COVID by the visitor bringing it in than you're going to get it from here.
So you're saying here is a very safe
This
place.
is a very safe place to be.
Yeah.
And that brings me to my second point. From a it's not so much a quality standpoint, it's from a community standpoint. There are people that are avoiding getting things done that they should. Now, some of those are preventative, colonoscopies and things like that, but we're still really concerned about people having symptoms of a stroke. I mean, stroke care has really changed. We're going through our accreditation today, but we can do a CAT scan in 15 minutes. We can give you medication that can reverse a stroke, the same way with heart attacks. And people have, and I don't think it's as bad here, and I think it is getting better, but they have put off, well, I don't want to go to the emergency room. I don't want to get COVID and end up having really serious problems, and understandable so, because, well, I don't know whether I want to get exposed to COVID. We are continuing to treat people for all of the problems that they had and we saw before COVID. And so just, again, the plea out to the community is if you've got those symptoms, check with your doctor, come to the emergency room. And again, financially at the end, I guess we would be better off, but we're concerned about community members.
Thank you. Any more questions or comments? 2, go ahead.
Are we learning that some residual damage from COVID can affect the brain?
Yes, I'll assume the question was, does COVID affect the brain? I think one of the things we're learning about the disease state and whether this is the virus or not is this, and it seems to be the problem is the autoimmune system, this hyper reactivity to what happens in some individuals that get COVID. I don't remember if the last time we talked, but where the big concern is about football players is about something happening to their heart, that they get an infection of the heart called a myocarditis because of an immune response that we really don't need. Maybe it's the virus being there too, but the combination of the two being a problem. We are starting to see, and remember, we've only been taking care of people for about 6 months now, so we don't know what it's going to be like in a year or so, but we are seeing things that are in the nervous system, including the brain. It seems to, there are certain people that are having more problems with that. I'm not going to say they're going to have dementias forever or whatever, but they're certainly, their mental capacity has been reduced. And that just makes sense from a standpoint of what one of the criteria we use to make the diagnosis now, that you can't smell, you can't taste. That's your brain. That's the brain stem that's being inflamed or infected or whatever term you want to use with COVID. I think there's going to be a subsegment of the population, whether they've been in a hospital or not, are going to have long-term problems with COVID. We seem to be seeing that, and we're trying to figure out who they are. Are they the individuals that are going to need long-term treatment with something else? That remains to be seen. It's a big concern.
And have any of the staff that have provided direct care tested positive for COVID?
I am not aware
I'm not
of
aware.
anyone. I'd have to say I haven't asked for a while. I would have said that I knew for sure a month or so ago, again, as far as I know, and that's across our system. We have been really fortunate, and I'd like to think because everyone has followed the protocols, have looked at things, and again, remember, healthcare workers, not only are they putting their lives online in the emergency room, they're going home where their kids can be bringing things home, their families, but people have really taken this seriously, even in their personal lives of what they've done. So with that being said, Tammy, I am not aware, but I could stand to be corrected. We have certainly not had individuals off. What my biggest concern when this all started was, are we going to have a workforce? Maybe we're going to have doctors. Now, we have had a couple doctors turn positive, so they would be associates, but so far we just haven't seen any kind of magnitude.
Now, the one thing we don't know, just to give a complete answer, we haven't tested everyone.
Yeah, that's good.
And as we all know, there's a fair number of people out there that test positive that had no clue that they had anything. So do we have some of those? It's entirely possible. We just don't know. Are we up to speed there?
Yes.
Thank you for those questions, by the way. George from Glandorf, and for those of you that don't know aren't from Ohio, Glandorf is west of Findlay. Do you, and this will be for you, Bill, do you have any, because my predictions are no good anyway, do you have any predictions of when a vaccine will be available? Is it something we should trust given the rushed nature of development?
Yeah, that's a really, it really is, it's a good insight into what's going on. I would say, let's say we didn't have all of the political aura around that when the vaccine came out and it would have gone through the usual trials, say it was an influenza. We get the same thing happens with influenza vaccine every year. Any vaccine, when HPV came out, it had gone through the trials. That people didn't worry about that. And so I think people are worried. I read, again, something over the weekend that less than 50% of the population said that they weren't going to take it whether we got one or not because they didn't trust it. So my advice to everyone would be, if it has gone through the trials, and it takes a while to do these trials. We're into the phase 3 now, which means I get the shot and let's say Scott doesn't, he gets the shot, but he gets the placebo and I do. So what's going to be tested? Well, one of the two of us get COVID. We're not going to be exposed that way. Did we develop the antibodies to see whether it should protect us? And it just takes a while for that to occur. So you can't, quote, rush that to make do. Now, whether I really don't think the FDA and the CDC and Dr. Fauci and what they're going to do. I mean, they've already said they will not put up with that, and I really do trust them. Now, how effective is it going to be? That would remain to be seen. The big reason for the trials, you want it to be effective, but you want it to be safe.
Yeah, safe.
We don't want people, okay, I got the shot and I end up with some kind of a weird disease or worse than what I had if I'd have had COVID. And so that's the importance. So I think that, I think we're going to get a good vaccine. I don't know whether we're
sometime next year, you think?
I think it's going to be next summer before it's, well, the one thing is, even if we get something that comes out, let's say in January or February, it's got to be mass produced. We got to get it to millions of people. How are we going to get all that kind of stuff done? And then we've got to get people to say that they're going to take it.
One of our values here is humor, and I'm going to tell I think it's a funny story real quick about this. I have a brother-in-law who's a physician leader at Vanderbilt University's medical school, and he wrote me a little note, said, I've volunteered to be one of the people you can trial the vaccine on. This one came from Russia. Now he's writing this to me, and there's been no effect whatsoever. In fact, I never even know it. And as he's doing this, the writing flips to Russian. So the whole rest of it's in Russian. He actually is a trial patient for a vaccine, and I think it's gone fine, but I thought that was pretty funny. He's a funny guy. Karen from Arcadia asks us, if you had the virus and recovered, would you still need a vaccine?
That's a really good question. I don't know what the recommendation is going to be. Theoretically, you wouldn't. And what we don't know, though, is how much antibody do you need to say that you're going to be safe? And so, okay, I got COVID. I got some antibody, but let's say I got 1 unit. Scott got it, and he's got 2 units. Well, is my 1 unit going to protect me from the COVID if it comes back around? And we just really don't know about how that's going to occur. There have been cases reported, not very many, but they've done it genetically to show it's the same virus, not a mutated COVID, that somebody got it 4 months later than when they had it and been sick enough to really know they had the symptoms and theoretically to have produced enough antibodies to fight it off. So I'm just going to, my supposition is going to be you would go ahead and get the vaccine. That even though it might be that you're going to be protected, but that will be a recommendation that will come out once whatever vaccine is produced and approved.
Part and parcel of what you're talking about is it's still a little unclear as to how long do your antibodies last.
Exactly.
For those of you who don't know, a cold is a coronavirus. And I think we all know that once you get rid of a cold, you don't get one real quickly again, but it doesn't take very long and you can get another cold. So is this like that? Or is it going to be different for different people? And we're still trying to figure that out.
Yep.
Which kind of leads into the next question. Nancy from Bluffton is asking, are antibiotics effective in preventing or treating COVID-19?
So in general, the answer is that an antibiotic of what I think of as an antibiotic is not effective at all. An antibiotic fights bacteria. Azithromycin was one of the original ones that was used along with HCT, the hydrochloroquines. There was some data because it works in between viruses and bacteria are bugs, germs called mycoplasma. That would be walking pneumonia. If you're, without getting too much into the detail, azithromycin seems to work for it. Not that it's closer to a virus or a bacteria, but there were some theoretical reasons why it might have been useful. The testing has shown it doesn't look like it makes any difference. Now, we do have some antivirals. There are some for herpes, AIDS or HIV is produced by a virus, and we have drugs that work for it. It's just that we don't have anything
Well, it
right now for
suppresses
corona.
it, but it doesn't.
That's true. It's really usually not a cure. It's a suppressant. Sometimes, though, you may be, quote, cured, not too often, because then your body takes over if you can get the viral load lower. But correct.
Larry from Finley asks, this is a good question too, what can people with diabetes do to protect themselves from COVID and or the flu?
Well, anyone that has any kind of chronic disease, specifically that was asked here is about diabetes, should do the same things as anyone else as far as what the protective things that we've already talked about. I would say to be even more so fastidious about making sure those things are taken care of. There have been some reports out that, let's say in diabetics taking zinc, that they may be better off. There haven't been enough controlled studies. Doesn't mean it may not be right. It may not be that helpful or what, but from a diabetic, the biggest thing I would say about this is keep your blood sugar well controlled. You want to take as good a care of yourself as you can so that you're at the same propensity, essentially, if your blood sugars are running fine, that you wouldn't have any more, because of high blood sugars are going to allow you to get more infected, and you're not going to fight the infection as well. So that would be the general what you'd say.
Bill, if I'm diabetic, and let's just say my blood glucose is well controlled, is there anything in a vaccine that would be dangerous to that?
Not that I am aware of, and that's not put on any kind of precautions. So if you take child vaccines and your immune system is okay, that we don't differentiate if you have type 1 diabetes. Now, if someone has not very many white blood cells, one of the big ones is chicken pox, or you worry about what's given for herpes zoster, the same bug, that could be a problem. But in general, for any age group, no.
Okay. Well, ladies, do we have any other questions? We do. Okay, good.
Yep. How long does it take for the long-term effects to show up? And do you see those effects in young adults too?
I think in general, it's a continuum. The question, if you didn't get to hear it too well, is how long does it take to see the long-term
Effects.
The effects.
And do you see it in younger people too?
Right. In general, it's not going to be like I had COVID, was sick, and got well, and then 2 months later, I had problems. It's going to be, in general, again, a continuum of having problems. I'm just not getting over it. The cardiac things may come on later, but I really still wasn't feeling very good. And then I started to get some chest pains. And that may be days, it may be weeks, it may hang on for 2 or 3 months of the things that we're seeing. The lung disease, the problem that I would see with chronic obstructive lung disease, COPD, people that have had lots of asthma, is that there may also be some destruction of additional lung tissue. So let's say my lung capacity was only 50%. Now I get COVID, and I may get over the infection, but it may have destroyed another, say, 10%. So I'm going to be more short of breath than what I was before. I never really recovered. The same thing could happen with pneumonia. But basically, it's a continuum that I just never got over that. That's going to be interesting to see what this mental capacity. Most people are getting back their taste and their sense of smell, from what I've been told. So we think that there will be a recovery, that at least those aren't going to be permanent.
But it's also safe to say, and I'm aware of, at least I've been told of, a couple of younger people that their taste and smell has been out of whack for months.
Yeah, that's true.
And they actually feel okay, but they can't taste and smell normally. So again, it's one of those, it seems to be indiscriminate in terms of age, probably more problems with older people and less with younger, but you can find situations that are pretty weird for younger people.
Yeah, New York City has had, because of the magnitude and of the percentage of the population, in addition to the number of people, quantity and quality, that they've been following I think 130 kids, adolescents under 18 that have had long-term sequelae from long-term symptoms from having COVID.
And how are things progressing with testing at Birchhaven?
Do you want to answer? I would assume we are doing the same things that we are be doing with testing. We are still making fastidiously to make sure that we're not going to spread anything by taking temperatures, by weekly looking and checking employees, as well as looking for symptomatic people. So we have not had any significant change of problems or anything, at least that I'm aware of.
New people coming into the facility are quarantined and tested, so we don't immediately put those folks into the population too. So we haven't had any outbreaks. We've had a couple people that tested positive. All in all, I think the job that we've done at Independence House and Birchhaven has been fantastic.
And one of the questions that we get quite often, and there's been a lot of discussion around, is now mental health repercussions in the community and the workforce. And so what are your thoughts on that? Not only kind of the post-traumatic stress of it, but as well as substance abuse and different things like that. What is your opinion on how that might go?
Well, I think we are concerned about that for some of the reasons that you mentioned. Just to start with, if somebody's lost their job and they don't know how they're going to feed their kids and if you weren't depressed, why wouldn't you be depressed?
If you weren't depressed, you wouldn't be normal.
Yeah. And so you just add that on to the normal stresses of living, in addition to being worried about getting an infection and all of those things going on. So then you take another subset of the population that already has problems. I think I happen to be on the focus board, and we've spent a lot of time talking about that with mental illness. And in addition to that, or substance abuse, is they're not going to have as much social support. So that individual, and that's one of the big things in our community, the ROSC of the recovery oriented, of having somebody you can talk to, that you can sit down, you can see, that's going to give you emotional support. That is really concerning about what's going on. The incidence of suicide is a concern, whether mental illness or however, but just being a bigger depth concerned about. I think this community has really tried hard to work as a community to do those things. We've been involved, if you talk to our director of nursing and the director of the emergency room, working with the community about how we can interact. I know the mental health and public health have been really concerned about that. So if public health is going out and they're seeing somebody needs to be quarantined, they're trying to check on them really frequently. How are you doing? Making sure we try to get them into resources. But we're like a lot of other communities. We don't have all of the resources that, let's say, it would be nice to have to be able to do that. It's a big problem. But I think the churches are trying. I know our church is. I know your church is, of trying to, again, reach out to people. I think getting kids back into school is going to be helpful that way too. It's going to be good for families. So it's a multifactorial answer question that people really are concerned. That if this lasts, we're getting into the winter now. I mean, Scott's right. It was nice to get out this summer, but when people, February is the sad month, seasonal affective disorder, those kind of things, we've got to really be careful because we're going to have problems.
Is that it?
That's it.
Well, that's good timing, because once again, we're right up against our hour. Once again, for those of you that have tuned in, thank you. Hopefully this was helpful. I can't emphasize enough our hope that you will give us feedback. Bill and I are proud to try and represent Blanchard Valley and what we're doing and the community, and we're happy to do it, but only if it's useful to you. So we'll close by, again, thanking you for being with us today, and we'll see you on down the road. Thank you.